You so much, Antenna. Let me share my screen here. That's it. Can you see my screen okay? Okay, so let me move you here and participant list here so I can see if anybody's raising their hands or asking questions. All right. Hi, everyone. Thank you for attending this DQ'd assembly event. My name is Olivia Jung, as Antenna mentioned. I'm an assistant professor in the Health Policy and Management Department at UCLA Fielding School of Public Health, and also a faculty associate at Laboratory for Innovation Science at Harvard, which is a lab within the Digital Data and Design Institute at Harvard Business School. And also here with me is Andrea Dorbu, who is a research associate at LISH. And the talk today is titled Innovation Contest in Federally Qualified Health Centers. So just so that we're on the same page, first, what do we mean by innovation contests? Innovation contests work by broadcasting a question or problem statement to a crowd or a large pool of people across knowledge domains or across organizational and professional hierarchies. So essentially decentralizes and democratizes the process of innovation or problem solving. And these kinds of contests have been around for a long time. One of the earliest versions of an innovation contest took place in 1714 when the British government offered a cash prize to anyone who could devise a practical method of determining the longitude while at sea. In more recent times, open innovation contests have tackled challenges ranging from the Frito-Lay's Crash the Super Bowl contest that invited consumers to create their own Doritos ad, to the NFL and Duke University offering up to $2 million for designing a football helmet that would better prevent brain injuries. So just to give you a sense of innovation contest. And another part of the title is federally qualified health centers. And what are these organizations? What are these health centers? As many of you who might work in the healthcare sector may already know, these organizations receive federal funding for operation. And to qualify for this funding, federally qualified health centers have to meet a certain number of requirements. They have to serve an underserved area or population, provide comprehensive primary care and supportive services like mental health services, dental services, transportation, social work, among others. They also have to have a governing board comprising community members and patients and meet a number of different quality and operational requirements. Here is a picture of a health center that we got to work with and visit in person in the past. This one is located in Quincy, Massachusetts. And in our work, we chose to work with these organizations, these FQHCs, for several reasons. One reason is that even though these health centers vary in size and location, they're also largely similar because of having to meet the different kinds of requirements for federal funding. So that allowed comparable implementation of innovation contests and evaluation of their impact across organizations. Second, there's a lot of pressure and demand on these organizations to improve the experience of patients, as well as to improve the quality, the equity, and cost of care. And so there's a huge need for innovation in these organizations. And lastly, many health centers face substantial and enduring challenges related to staff recruitment and retention. And so a fun activity like generating ideas and then voting that are associated with innovation contests could be used to motivate staff to be engaged at work and participate in organizational problem solving with their peers and colleagues. And we had the opportunity to work with a national sample of 54 FQHCs. Here's a geographic distribution of the participating health centers, and the significance of the red and the black dots will be explained in a little bit. And more on the characteristics of these participating health centers. About 40% were located in rural areas versus urban. About 3 in 4 achieved a patient-centered medical home certification. On average, organizations employed about 200 workers, which included physicians, dentists, advanced practitioners, nurses, social workers, and other kinds of support staff. And in terms of the innovation contest, this intervention comprised sequential elements or sequential phases. And it started with the promotion phase, which began with senior managers of these health centers introducing the concept of innovation contest to employees. And to standardize the information shared with all the organizations and the employees in those organizations, I asked the senior managers that I was working with to use the materials and the language that I created to promote this innovation contest. And the contest itself began with a 3-week-long ideation or idea generation phase. And that entailed describing a work issue and then proposing a solution. And we asked for ideas that would improve patient care. And this prompt was intentionally kept broad because we wanted anybody to be able to participate and give an idea, regardless of their educational level or professional expertise. And this part was followed by a 3-week voting phase. And here again, everybody was invited to participate, and voters were asked to indicate the extent to which they wanted to see each of these ideas implemented on the scale of 1 to 5. And that process determined the contest winners and runner-ups. And some organizations used social media to recognize their winners. And across all participating health centers, about 15% of the employees participated in ideation or idea generation, which meant it generated more than 2,200 ideas by 1,400 staff. And in terms of voting, on average, about 40% participated across the health centers. And in terms of people who participated in idea generation, we saw a wide range in terms of the roles represented. So about 40% of the staff were considered non-clinical support staff. So people like receptionists, people who sit at the front desk, referral coordinators, billing staff. About 22% of the people who participated in idea generation were clinical support staff. So people like medical assistants, dental assistants. 13% were health professionals, dietitians, behavioral health therapists. About 9% were advanced practice nurses, like nurse practitioners and physician assistants. And then another 8% were physicians and dentists, and about 6% were nurses. And so in this talk, we organized it by 3 published and working papers. And each of these 3 papers try to answer these 3 questions. 1, what do frontline staff in federally qualified health centers think about? What helps or hinders federally qualified health centers and their staff from participating in innovation via innovation contests? And lastly, can innovation contests as an intervention cause these frontline staff in FQHCs to become interested in organizational innovation and keep speaking up with ideas? So we're gonna start with the first paper that tries to address this first question. In a paper titled Ideas from the Frontline, Improvement Opportunities in Federally Qualified Health Centers. The QR code here, when you scan it, it'll lead you to the paper, this published paper, and it's open access. So anybody in this talk and not attending this talk can access this paper. Our goal is to, for these papers to be helpful for people who are running health centers and running healthcare organizations. And so feel free to scan and read the paper at your own time. And we also encourage people to chat in any questions or raise your hand if you have any clarification questions as we go through these papers. So my colleague Andrea is going to go through this paper, so I'll turn it over to her.
All right, next slide. Okay, so in this paper, we performed a content analysis on a large number of ideas that were generated by frontline employees, and that was done through coding. And coding ensured that the knowledge from our analysis was grounded in the data or participating FQHC's employees' unique perspectives. So in the first round of coding, the first and second authors read submissions and inductively developed a list of codes and definitions of codes. Authors met once a week to refine the definitions, discuss progress, and possible modifications. After going through these ideas, the authors sorted the codes with conceptual overlaps and similarities into categories. For example, standardization, office space and supply, etc., were categorized as operations. And then in the second round of coding, the first and second authors split up the work by reviewing ideas by code. For example, the first author reviewed the ideas filed under staffing and staff training, while the second author reviewed the ideas filed under workplace perks and compensation. Both authors continued to check their ideas that were coded and organized according to the scheme from round one of coding, and then recategorize the ideas as needed. And the authors also continued to meet weekly. Based on the coding that was conducted, we were able to create a distribution of ideas into categories and codes as shown in the pie chart, and I'll be going over the pie chart shortly. Okay. So this multi-ring pie chart illustrates the 2,200 ideas that were generated from about 1,400 frontline clinicians and staff. The ideas from the frontline FQHC clinicians and staff were categorized into three main thematic categories: operational improvement, which was about 39% of ideas, employees, 35% of ideas, and then patients and community, which was about 26% of ideas. On average, 15% of FQHC employees contributed ideas, with the participation in ideation range, which was about 2.7 to 40%. On average, 41% of employees participated in voting, and that ranged from 12 to 79% among FQHCs. And these stats are similar to participation rates in similar contests. Respondents' information that we had, 40% were clinical support staff, 22% were 40% were non-clinical support staff, 22% were clinical support staff, 13% were health professionals, 9% advanced care nurses, and then 8% were physicians and dentists, and 6% were nurses. And I'll provide some examples of the ideas in the following slides. So in this portion, we'll be looking at some example ideas from the category of operations, and operations refers to improvements to day-to-day functioning and activities in health centers. One of the codes for operations was standardization, and an example idea that we had in this category was to develop a standardized method for receiving/sending all medication refill requests at all locations. And then in another example, code was scheduling and access, and an idea that was generated was: we live in a low-income cash pay only community, and visits need more time per patient to address more concerns. And then another code was technology to aid operations. An example idea was to transform our clinics into a less wasteful and more energy efficient space by using tablets for paperwork. And then our next category was employees, and this category referred to ideas pertaining to employees. One code was staffing, and an example idea we had was to hire more referral coordinators. And then another example code that we had was staff training, and an idea was to create a promotion path for entry/mid-level staff by offering training that expands skills and job scope. And then the next code, workplace perks, and then an example idea was to celebrate social workers and case managers during the National Professional Social Work Month in March. And then our last category was ideas on patients and community. And so a code in this category was patient experience. And an example was a loyalty program for patients like they do at supermarkets and hotels. And then another code was patient communication. And an example idea was to send out text messages to confirm appointments. And then another code was new service. And the example idea was to create a mobile food pharmacy to distribute healthy foods to our diabetic population and develop the program with our staff dietitians. Okay, discussion. So there are about 2,300 impactful ideas generated by frontline employees about issues needing to be fixed. These ideas can help influence managerial and policy priorities to help decision makers determine which improvement opportunities to prioritize. Next, about 40% of the ideas called for improving day-to-day clinical and administrative operations. Many ideas were deemed as most feasible to implement by senior managers, and these ideas called for more standardization. So interventions that standardize work and improve inconsistencies may be easy to implement, achieve operational efficiency, and enhance provider and staff experiences. Supporting employees was also another large category of ideas. Frontline employee shortages and frequent turnover are longstanding critical challenges faced by FQHCs, and fully staffed clinics experience lower burnout and spend less time on work than someone with less training would do. So policies that enhance staffing and safety net clinics, for example, policies that call for more financial incentives that support providers who choose to work in underserved communities may help employees feel supported and alleviate concerns about staff resources and the capacity to provide quality and accessible care.
Thanks so much, Andrea. So in the second paper of the three papers that we prepared to share with you today, this paper tries to answer the question, what helps or hinders FQHCs from participating in innovation via innovation contests? And this work is also in a published paper titled Employee Engagement and Quality Improvement and Patient Socio-Demographic Characteristics in Federally Qualified Health Centers. It's a paper from the same overarching project. And in this work, we think about people's participation in the innovation contest as giving ideas, participating and voting, as engaging in quality improvement work. Again, the QR code there will lead you to this paper. So as many of you know, there are numerous challenges to engaging frontline staff in quality improvement work in federally qualified health centers, but in many organizations more generally. First, because QI-related tasks are often not part of formal responsibilities for most workers in healthcare organizations, and time and resources are, as a result, primarily spent on patient care. So time and resources are limited for QI, quality improvement, or innovation. And many of these staff and organizations are already very stretched thin. And when people are busy and overstressed, their ability to reflect, learn from experiences, participate in extracurricular activities may also be compromised. And there are reasons to believe that socio-demographic characteristics of patients in a given health center or given healthcare organizations are associated with employees' ability or capacity to engage in quality improvement or innovation. First, patients living in poverty, according to research, they've been shown to be more likely to have low literacy, reside in poor quality housing, and have more complex healthcare needs. And all of these could increase the overall workload and the work-related stresses for the staff. And with respect to the racial and ethnic composition of a health center population, health centers that serve a higher percentage of Black and Hispanic patients have been shown to have less access to medical supplies and referral specialists, and be more likely to have physicians who report working in chaotic work environments and low job satisfaction. And so in health centers that see more patients who have fewer resources and greater healthcare and social needs, workers may feel that they're unable to engage in quality improvement. So as we mentioned before, about 15% and 41% of the employees in our sample participated in idea generation and voting, respectively. And the percentage of patients living in poverty ranged from 17 to 93%. It's shown in this part of the table. The percentage of Black patients seen by these FQHCs in our sample ranged from 0.3% to 97% here. And then the percentage of Hispanic patients ranged from 1% to 85%. And so surprisingly, we see a big range here, even though all federally qualified health centers are dedicated to serving underserved areas and populations. And for my nerdy colleagues in the audience, I then took the percentage of employee participation as my outcome variable, and then the patient sociodemographic characteristics as my independent variables to conduct regressional analyses to see if there are correlations between these two variables. And here are my results. What these results show are that FQHCs that see a higher percentage of patients living in poverty had a lower percentage of employees that participated in both idea submission and voting, indicated in the blue circles. And the FQHCs with a higher percentage of Hispanic patients had a lower percentage of employees who voted on ideas, indicated in the gold circles. And the percentage of Black patients did not seem to be associated with our outcome variables, whether the percentage of people who participated in the innovation contest. So what do these results mean? Many healthcare delivery organizations face resource and personnel constraints in their efforts to improve quality of care. And this study shows that these constraints may be more present in organizations that serve a higher share of low-income and/or Hispanic patients. Because we find that in those health centers that serve a higher share of low-income and/or Hispanic patients, fewer employees participated in idea submission and voting. But this isn't to say that health centers should see fewer patients from underserved populations, but rather we believe that this finding highlights important resource and personnel constraints in those health centers that reduce employees' capacity to contribute to quality improvement efforts. And our hope is that in those health centers, and that those health centers could cite this paper when applying for funding, et cetera, so that they could keep seeing patients without adequate access to care while encouraging their employees to keep innovating and engaging in quality improvement. And finally, paper 3 of our 3 papers, this paper tries to answer the question, can innovation contests cause the frontline staff to become interested in organizational innovation and keep speaking up with ideas? And the motivation for this study came from doing some interviews with people who participated in similar types of innovation contests, but that was done in Mass General Hospital in Boston, Massachusetts, a longtime research partner of mine. So again, these interviews were done in hospitals, in a large academic hospital, after conducting one of these innovation contests. And so when I talked to some participants from this hospital that participated in this contest, these were some things that I heard. So one person said, innovation contests sent a message that any of us can participate in innovation or quality improvement projects, and that senior managers care about what everybody has to say. Another person said, the idea that won the contest has created a lot of interest in cost containment. So that idea had to do with putting cost labels on the items in their inventory closet. And so this person said, it's raising awareness, that idea is raising awareness, it's caused other people to be critical of things that they weren't aware of before. And so hearing things like this suggested to me that running innovation contests might signal to employees that their input is valued and potentially grow their interest in organizational problem solving. And so it made me wonder if a formal structure that taps on employees for ideas like the innovation contest could be used as an intervention to cause people to keep speaking up with ideas. So I hypothesize that implementing innovation contests will cause employees to indeed become interested in innovation and keep speaking up afterwards, because a formal structure can signal to employees what their expected behavior is and suggest to them what their input is welcome and that it's valued. And intervention like the innovation contest or any kind of crowdsourcing mechanism could democratize the opportunity for staff to participate in innovation, which often, especially in healthcare organizations, but in other organizations too, which often happens top down, originating from senior managers or a policy change. And so again, as we mentioned before, there were 54 federally qualified health centers that participated in this project. And with that sample, I divided them into 4 groups, whether the health center is a patient-centered medical home or PCMH, which means that they've met certain requirements in terms of their quality of care and care coordination capabilities, and also by whether the organization is located in a rural or urban area, because these variables have been shown to affect health centers' clinical performance. And I got a question here asking about the incentive participation for health centers that already have, limited time and resources, especially for the staff, and how we try to work around that is really emphasizing that this innovation contest participating doesn't take a huge amount of time. It's kind of we compared it to kind of posting on Twitter, like you just log in to this platform and it takes just a few seconds to, type your ideas, whether you're on a computer, you could do it on a computer, or whether you could also do it on your phone. And so we try to really emphasize the time, the little amount of time that it would take for people to participate. And then in terms of health centers, as I was recruiting partners to work with, I also emphasized that I would take on a lot of the work, helping to run the innovation contest. And you might remember in efforts to standardize this intervention, I also helped to create the promotional materials and the language and the platform for the innovation contest too. That these health centers could use. So again, at the organizational level and at the individual level, try to really emphasize that the time involved in running this contest and participating in this contest would be try to be kept minimal. And then for the next question, I'll come back to it in a bit. So going back to working with these FQHCs and then stratifying them by their organizational characteristics. Once that was done, I randomly assigned half of them to treatment group and the other half to control group. So the treated health centers conducted the innovation contest and the control group health centers did not. And this was to, again, test the causal effects of running an innovation contest on people's becoming interested in organizational innovation and speaking up with ideas. So you've seen this map before. Got to work with 54 FQHCs, and the red dots indicate the treated health centers, and the gray dots indicate the controlled health centers in our study. And this brings up to the question then, how do we measure behaviors like becoming interested in innovation and speaking up? We primarily used survey data for this. We surveyed all of the employees in participating health centers. The response rate was around 60%. And for people who self-identified as supervisors, we asked them to assess the behaviors of people that they manage. We asked them to agree or disagree with forgiven employee, whether he or she makes suggestions about ways to improve work processes and patient care, whether he or she generates creative ideas, whether he or she promotes and champions ideas to others, and whether he or she develops plans and schedules for the implementation of new ideas. And then we also asked employees to self-report their perceived psychological safety, or the perception that it's safe to take interpersonal risks, to speak up, for example, to challenge the status quo. So people were asked to agree or disagree with items like, in this organization, it's easy to speak up what's on your mind. People in this organization are usually comfortable talking about problems and disagreements. I should also note that these items were developed and validated by prior research. So in all organizations, we conducted a survey measuring the items that I just described to you in the previous slide. The only difference between these two groups was that that I ran the innovation contest in the treated organizations, and that in the control group, I did not. So all else being equal, the only thing different about them should have been that the contest was done. So again, for my nerdy colleagues in the audience, this slide is to show that randomizing worked. I compared the treatment and control group health centers on a number of different measures, and as expected, at baseline, before we ran the intervention, we did the innovation contest. Both health centers in both groups were likely very similar, supporting the claim, again, that the only thing different about these organizations was that innovation contest was run in half of the group and not in the other half. And this basic bar chart gives us the first impression of the results. To orient you a little bit, the gold bars represent results from the control group health centers, the percentage of staff from control group health centers that agreed with the given statement. And then the blue bars represent results from the treatment group health centers, percentage of staff from the treated health centers that agreed with a given statement. And the difference between the two bars represent the impact of the innovation contest. So the percentage of staff voicing suggestions was about 8 percentage points higher in health centers that conducted the innovation contest compared to those that did not. But the percentage of those generating creative ideas was about 12 percentage points higher in the treatment group health centers. And the error bars, that's the small eye-like shaped figure above these bars, indicate that the increases in the voice, in the speaking up and related behaviors are statistically significant. And same was true for the percentage of employees who promote and champion ideas and implement ideas. And the percentage of employees expressing psychological safety appeared to be similar between the two groups of health centers. And these results also hold in regressional analyses. If you would like more information on that, please feel free to reach out. And so how did it work? To understand, the underlying mechanisms behind how innovation contests, managed to running this intervention, increase people's speaking up behaviors and interest in organizational problem solving, I had the opportunity to interview some participants after the contest. These are some preliminary findings. But one thing that I kept hearing is that maybe managers, through running this contest, learned that staff had valuable input, so they kept asking. So it seemed like the contest had an impact not just on the frontline staff, but also on the managers, the middle managers, the frontline managers who learned that staff had really important input to share. So one senior manager shared in an interview that for me, what I took away from running innovation contests was that staff have fabulous ideas. Their ideas are able to elevate us, but we don't have formal mechanisms to capture them. And one medical assistant said, there's more conversation around ideas. The management team is pushing people to continue to share ideas. I think the innovation contest has helped to open up that conversation. So it seemed like running the innovation contest perhaps prompted more organizational practices or processes that were enacted by managers so that staff could share more ideas. And then from the employee side, it seemed that employees also learned to prioritize improvement opportunities. So one volunteer engagement specialist said, the innovation contest has gotten me to think more critically. Before, you just work day to day. But the innovation contest got me thinking, like, what else can I think of to improve my workplace instead of just going from day to day to day to day? And so this study, we believe, sheds light on the broader question of prompting employees to speak up when they have useful information and ideas. And our findings extend our understanding about how managers solicit staff input and suggest that that managers can be more direct in their ask for employee input. This study also shows that innovation contests can specify the occasion and outlet for staff to speak up with ideas using a transparent and structured process, such as voting, where people can see all the ideas that came out in the idea generation phase and getting to participate on which ideas that they want to see implemented. And lastly, the study also shows that innovation contests have the potential to shape behavioral norms around speaking up with ideas and suggestions. So this brings us to the end of the slides that we prepared. We would love to hear any questions or comments. We could try to address them here now, or you're also welcome to email us in the email addresses listed here. Also have a Twitter account, and would love to hear from you. And yeah, so please feel free to reach out.
Thank you so much, Olivia and Andrea, for taking us through this fascinating research study. We do have a couple of questions in the chat that we haven't addressed yet. So I'm going to start with Jenny's question. So Jenny asks, how much effort does organization need to invest in innovation contests?
That's a really good question. I think there are two things. One, running innovation contests itself is not super challenging. You know, I use Qualtrics or like a survey tool to, generate to create a platform through which employees could, share ideas and then have people vote on ideas afterwards. I think so. Running the innovation contest itself and then hearing from staff might not take as much effort, but the before work and the post work might take more work. So for example, what I mean by before the pre-work is, creating the cultures and the environment where people, want to share ideas, they feel safe speaking up with ideas, that might take effort. And then innovation contests are designed to, solicit ideas. And so what to do with those ideas afterwards, making sure that staff feel heard afterwards, even if ideas can't be implemented, acknowledging that their ideas have been heard and here are some actions that we're taking to implement them, or here are some reasons why we're not able to implement them at this time. And so there might be more efforts required before and after running the contest, but running the contest itself, I would say, does not take too much effort in relation to that. And Victor also asked a question some time ago with regard to constraints associated with lower participation in ideation. To what extent are business culture and versus ethnic culture versus workload, understaffing, constraining participation? That's a really good question too. In the question that in the second study that we shared, that mainly focused on patient sociodemographic characteristics and associated potential workload and understaffing constraints, and we find that that is the case. It's also very likely, as I mentioned before, the pre-work that's required to get people to participate in innovation contests, creating the culture where people, inclusive, equitable culture where people, no matter what their job title is or how long they've been working at their organization, I think that also plays a big part. Unfortunately, we were not able to disentangle that in that study, but I think that the culture definitely plays a big part in getting people to participate, in addition to in addition to the workload and constraints for innovation. I see somebody.
Yeah, we do have a question from the audience. Bohdan, if you can unmute yourself and ask your question, please.
I know it's hard to mute sometimes, like Zoom can be finicky.
Meantime, if people have questions, please feel free to send them through the chat tool, and also raise your hands and directly present your questions to Andrea and Olivia. fact, there is one, as Bohdan is figuring out how to unmute. There's a question via the chat tool by Juan. I hope I'm pronouncing your name correctly. I apologize if I'm not. She asks, or he asks, do you plan to continue more innovation contests with more health centers?
I think the answer is yes, and some other projects in the pipeline. Yes to doing more innovation contests, and because there's a lot of questions to answer around how do we even motivate people to participate when people's day-to-day job doesn't necessarily focus on quality improvement or innovation, how to encourage people to participate even if it takes a little time. And currently I'm also developing another project where innovation can be thought of as generating ideas and also implementing ideas. And so I'm currently developing a proposal for a project that focuses on that later part, what happens to ideas once they've been implemented. And for that proposal, I am proposing to develop and pilot test like a checklist aid, checklist-like aid that teams in FQHCs tasked with innovation and quality improvement can use that would support and guide and structure the innovation process in terms of, are we for example, like in a given team meeting where they're tasked with innovating and improving quality, where teams could use this aid or checklist to track, what ideas are being voiced, who's speaking up, who's not speaking up, are we thinking about internal, external stakeholders, and yes, definitely planning to continue to work with FQHCs. Especially because the work that these federally qualified health centers do is so critical and important in expanding care to people in populations and areas that are underserved, and also to improve the equity, cost, and quality of care in those organizations.
There's one more question from Victor through the chat channel, and I'm going to see if I can unmute Bohdan from my end. But in the meantime, the question from Victor reads, are there any findings regarding an effective mechanism for sharing of ideas across the organization without filtering, quote unquote, through the management hierarchy without eroding that same organizational hierarchy?
Yeah, that's a really good question. There's a huge body of research in the field of organizational behavior and management around voice behavior. And voice behavior refers to people speaking up when they're not always asked to, like volunteering ideas and suggestions that are aimed to improving organizational functioning. And that huge body of literature, talks about, what are some like environmental characteristics or individual characteristics or management practices that, you know, hinder or facilitate people speaking up. And our study tries to contribute to that literature by showing that something like the innovation contest or like open innovation crowdsourcing mechanisms would exactly do what you mentioned, you know, filter sharing of ideas without filtering like across organizational hierarchies, because these contests, you know, aim to solicit ideas from everybody. So again, I don't know if I try to be clear about this in my slides, but these contests really, you know, invited everybody in the organization, regardless of their job title, their organizational tenure, across organizational professional hierarchies, because we know that a lot of these hierarchies are very present and felt in healthcare organizations. And so I think innovation contest is one of those mechanisms that would allow sharing of ideas across the organization, across the hierarchy. The second part of your question is interesting, without eroding that same organizational hierarchy. I think in some aspects it attempts to erode that hierarchy by allowing people to speak up when they're not traditionally in positions to speak up. Yeah, hope that answers your question, but feel free to ask any follow-up questions. These are really the questions.
Excellent. And I think Bohdan is ready to present his question.
Can you hear me now?
We can hear you. Yes.
Great, thank you. You know, those settings sometimes get the worst of you. I'm actually a physician. I did health policy and management at the Harvard School of Public Health. I trained in Canada, and I worked for 13 years in a FQHC. I'm thrilled by this conference because FQHCs have been long neglected. And I can tell you that in my clinic, which I worked in, with a community that our family had a different community, which my family has had contacts with for 3 generations, going back to Eastern Europe. I had a boss who had less than an 8th grade education, and our medical assistants, who were all immigrants, many of whom were terribly depressed, did not know how to take a weight, did not know how to take blood pressure. So this is a very important element in terms of upgrading such services. So I've actually sent you emails on this, and but we have to understand the reality. I trained in Canada, and everybody has health insurance in Canada, and so everybody has the same price. And I found it very kind of almost sad that the policy that you found that helped was a cost-cutting measure in a clinic that serves poor patients. You know, in a country which spends more healthcare than the next 10 countries combined. So we have a serious problem. And I can tell you that my clinic suffered terribly during the COVID pandemic. And I tried to get the CDC involved in that clinic in the 1990s because I foresaw this problem. So we have a lot of work to do in this country. And I sent you emails, and I would love to work on this because I had to develop innovative approaches to provide the most basic of care. And I was a misfit in the clinic in the sense that I was not from that community. And I had trained in a healthcare system with universal healthcare. And so I came with very different attitudes. And so this is you've come in and taken a snapshot of what is going on, and your work is very important, and we have to find out how to expand it.
Thank you for that comment, and thank you for attending this talk. I'm always thrilled to be able to connect and share work with FQHC providers, staff, and clinicians. And so thank you for being here, and thank you for that really important comment. And looking forward to connecting with you.